be better for the general population.
Okay. Very well, thank you.
Could you help me, please? May you help me, please, because I can open the camera, the web, because I only see the signal of the meeting.
But
It's for you, Mr. Nestor.
Okay. Hello everyone. I'm Nestor Sherman. Since Professor Pedro Ruiz, President of the WDD, the World Association on Dual Disorders, is not able to be here to be with us today, in my capacity as Vice President, I would like to give a warm welcome to all of you to the 4th WDD, the World Association on Dual Disorders Congress. Thank you to all friends, colleagues, and WDD partners from all over the world that support us and contribute to this meeting. And above all, thank you very much to the President of the Congress, Professor Paez, who had worked hard to make this Congress possible under very difficult circumstances. Thanks, Mehdi. We greatly appreciate your work and your efforts. Finally, I hope all of you enjoy this meeting. See you soon. Bye soon. Thank you.
Thank you, Nestor. I would like as well to welcome all of you to this 4th WAD Congress. I would have liked to meet you in the beautiful city of Marrakesh as initially planned, instead of virtually. But unfortunately, this has not been possible this time. I hope that we meet in a relatively near future. I would like to thank the WAD committee for the trust they placed in me for organization of this Congress, and I hope to be up to this challenge. I would like to thank everyone who have made this meeting possible. And first of all the colleagues and friends who accepted our invitation, like speakers, to participate on this Congress. They are high-level professionals whose contribution will make this Congress a first-class one. I am confident that we shall share ideas and experiences will be of great use and interest for our daily practice and research. I would also like to thank my colleagues from the Moroccan Association of Private Psychiatrists Committee, and more particularly the small committee, the organizational committee made up of President Kadri and Dr. Yassin Anwar and Hajar Mehdi. I would like to thank also Lucia Garagorri from the WAD Secretariat and Professor Al-Omari and the Moroccan Association of Hydrology for their support and collaboration. Also the pharmaceutical laboratories for their support. And last but not least, to thank the interpreters in advance for the work that will be done to facilitate communication between us. Thank you all, and welcome and enjoy the Congress.
Ms. Nadia, is for you. Active your microphone, please.
Thank you. مساء الخير. Good afternoon. The members of the Moroccan Association of Private Practice Psychiatrists are pleased to welcome you today in a virtual Marrakesh of the Joint Congress with the World Association of Dual Disorders and the Moroccan Association of Addiction. We thank all speakers who responded to the invitation despite the exceptional circumstances we are going through. We would have liked to receive our guests in more hospitality in Moroccan traditional way, but I hope it will be for next time. Thank you.
Mrs. Amari, is for you.
Thanks, Mr. Chair, and Good afternoon, good evening, good morning, or good time to everybody. First of all, I would like to thank Professor Mehdi Payez and the WADD board for the Moroccan organization of the 2020 WED event. We wanted to have you in Marrakesh this year, but this coronavirus made things difficult. Many thanks to AMPEP through their very dynamic president, Professor Nadia Qadri, for this organization. The Moroccan Association of Addictology is to say pleased to be associated to such an important scientific associations. WED, AMPEP, and AMA will together offer 6 scientific days to mental health, addictology, and dual diagnosis professionals. A variety of conferences and well-known speakers will offer for sure a promising debate around this concept of dual diagnosis. We need now more research to understand this disease. Thanks again to Professor Mehdi Payez for bringing this Congress to Morocco, even virtually. We all know how hard you worked to make things happen. Finally, I would like to welcome you all to the Moroccan Association of Addictology 3rd National E-Congress, which will be held on 23rd and 24th October, starting 3 p.m. Moroccan time. The access is free through our website. Thank you for attending this event. I wish you a very nice Congress. And as we say in Moroccan dialect, مرحبا بكم.
À vous, Monsieur Payez.
Yeah, thank you. Well, it's a pleasure for me to begin with this first session of the WAD Congress. And it's a pleasure for me to give the floor to Professor Potenza. As Nestor said, Professor Potenza doesn't need to be introduced. He's very well known, and for the few people who don't know him, is Professor of Psychiatry in the Yale Medical School in the United States. He's director on addiction at Yale, director also from Yale Gambling Center of Research Excellence, director Women and Addiction Core, Women Health Research at Yale, and a lot of several things. And I give you the floor, Professor Potenza, who shall talk us about gambling disorders, neurobiology, psychopharmacology, and dual disorders. You have the floor, Mark.
Thank you very much. Thank you for the very kind introduction and for the opportunity to present in this conference virtually. It would have been delightful to have been there in person, but I'm grateful for the opportunity to be able to communicate via this forum. Like I do with my presentations, these days I have a listing of disclosures with respect to relationships with pharmaceutical gambling, gaming, and legal entities. And today I thought I would talk about dual disorder considerations for gambling disorder and how these conditions may be linked by shared genetic factors, and then what the implication is then for how we might think about treatment for people with gambling and dual disorders. Then focusing on pharmacological interventions, but then also thinking about transdiagnostically, what are some of the clinical features that might cut across disorders and what the neurobiological underpinnings might be, and then to think about how we might best use this information to advance prevention and treatment strategies. So dual disorders are more the norm than the exception for people with gambling disorder. Data from the National Comorbidity Survey Replication Study found that 96% of individuals with gambling disorder have one or more additional psychiatric disorder, and close to 2/3 have 3 or more. And given this situation, the dual disorders might provide guidance to clinicians about which treatments might be most effective for particular individuals. And this might be particularly important for pharmacotherapies. And this is, these are data from that study by Kessler et al. That we have tabulated in a recent Nature Reviews Disease Primer article on gambling disorder. And it shows that for cutting across multiple groups of disorders, substance use disorders, impulse control disorders, affective disorders, including both anxiety and mood disorders, there are high rates of co-occurrence. What is not shown here is that personality disorders also frequently co-occur. So this is perhaps an underestimation of the true dual considerations. So this raises a question as to how much of this co-occurrence might be driven by genetic and versus environmental factors. It's been long known that gambling disorder aggregates within families, and twin studies offer an opportunity to try to estimate the environmental and genetic contributions. And so this is one study that we conducted now going back 15 years, where we examined the relationship between gambling disorder and major depression. And what we found was that there was an elevated odds of 4 between the two disorders. And this remained about the same when adjusting for sociodemographic differences. And what we also found was that when we adjusted for other co-occurring disorders, the odds ratio dropped from 4 to 2, still statistically significant. But it suggested that other substance use disorders, personality disorders, and anxiety disorders accounted for some of the variance in the relationship between gambling disorder and major depression. However, as these were twin data from over 7,000 male twins, we could estimate the genetic and environmental contributions to each disorder and their co-occurrence. And what we found was that for gambling disorder, what was then termed pathological gambling, about 2/3 of the variance was genetic in nature and about 1/3 environmental in nature. For major depression, it was about 40% genetic and 60% environmentally determined. However, the best fitting model suggested that the overlap between the disorders was largely genetic in nature, suggesting that there are some biological features that account for a vast component of the co-occurrence between gambling disorder and major depression. So by applying similar analyses to other co-occurring disorders, we found that gambling disorder and generalized anxiety disorder, gambling disorder and stimulant abuse and dependence, that these relationships appeared predominantly linked to shared genetic factors. But those between gambling disorder and panic disorder and illicit substance use disorders, or societally acceptable ones, like alcohol abuse dependence, tobacco, use disorders and cannabis use disorders appear to be linked to both genetic and environmental factors. So a question then arose as to how can we use this information to influence our treatment approaches to individuals with dual disorders. And the shared biological contributions suggest that some treatments that might be helpful for other psychiatric disorders that co-occur with gambling disorder might also be helpful for the gambling disorder. And so we thought about some of the possible neurotransmitters that may contribute to aspects of gambling disorder or more broadly psychiatric conditions, thinking that systems like norepinephrine systems were linked to arousal and excitement, serotonin to behavioral initiation and behavioral cessation, dopamine to reward and reinforcement, and opioids to pleasure and urges, and that these might cut across gambling and other disorders. So focusing on the serotonin system, there were data going back now several decades that have linked low levels of the serotonin metabolite, 5-hydroxyindole acid, to impaired impulse control. This was found in individuals with alcohol use disorder, individuals with antisocial personality disorder, and was also found in individuals with gambling disorder. And individuals with these impulse control disorders or disorders involving impaired impulse control showed different behavioral and biochemical responses to serotonergic drugs. For example, the 5-HT1 and 5-HT2 receptor partial agonist MCPP, M-chlorophenylpiperazine. Additionally, and so the individuals with the impulse control conditions tend to report a high or buzz in response to the drug, whereas individuals without the disorders reported a more aversive response. And when brain imaging measures were used to assess responses to MCPP or to fenfluramine, individuals with impulsive aggressive behaviors showed blunted responses of the ventromedial prefrontal cortex. And we thought that this might be relevant to individuals with gambling disorder. And it also raised the question as to whether serotonergic drugs might be helpful for individuals with gambling disorder. And some initial reports out of the University of Minnesota found that paroxetine, a serotonin reuptake inhibitor, was superior to placebo in the treatment of individuals with gambling disorder. However, a subsequent multi-center study failed to replicate that finding, where one can see here the percentage of responders in the gray bars to active paroxetine and in the black bars to placebo. And what we observed in this study was that although more than 50% of individuals were considered responders in the study, there was not a significant difference between paroxetine, active paroxetine, and placebo. So approximately 59% of the individuals receiving paroxetine were responders versus 48% of those receiving placebo. And so it points to this high placebo response that may make it difficult to identify drugs that are helpful for people with gambling disorder. However, we did see variability in response, and we thought that perhaps we should take into account co-occurring or dual disorders. And we embarked on a study of individuals with co-occurring gambling and anxiety disorders. And what we observed in the open label arm of this escitalopram trial, another serotonin reuptake inhibitor, was that over the 8-week course of open label treatment, there was a somewhat parallel and concurrent decrease in anxiety and problem gambling severity. What's not shown here is that individuals in this double-blind discontinuation study who were randomized to placebo showed worsening, and those who were randomized to active drugs showed sustained improvement. This was a small study, so one should take it cautiously, but it suggests that we can use dual disorders to guide treatment selection. Now, another condition that often co-occurs with gambling disorder is alcohol use disorder, as shown here in this public health promotion poster for the Connecticut Department of Mental Health and Addiction Services. And there is reason to be clinically conscious of these dual disorders because individuals with dual gambling and substance use disorders tend to have more severe symptoms, as evidenced by greater suicidality and more inpatient admissions for psychiatric stabilization and detoxification. And so we wanted to understand how gambling disorder might impact treatment outcome in a study of US veterans who had dual alcohol use disorders and other mental health concerns. And in this study, we assessed gambling disorder in 174 patients who were enrolled in a randomized controlled trial of naltrexone and disulfiram, or antabuse. And we found that 6% had met DSM criteria for gambling disorder, and about 1/4 of the sample had one or more features of DSM for gambling disorder. So we labeled those individuals as having at-risk problem gambling. And we found that the at-risk problem gambling group, those individuals had poorer alcohol treatment outcomes, particularly with disulfiram, and that this group showed less improvement in multiple non-alcohol, non-gambling psychiatric domains. Again, this could be that by not targeting the gambling behavior or disorder, that this may lead to a poorer treatment outcome. So what do we know about the pharmacotherapies for alcohol use disorder, given the shared contributions between gambling and alcohol use disorders? There are multiple medications that are approved that have FDA indications in the United States, for example, for the treatment of individuals with alcohol use disorders. These include disulfiram, naltrexone, and acamprosate. I should note that there are no medications that have an indication for gambling disorder. And we thought that of these three medications, and perhaps consistent with the prior study, that naltrexone and other opioid receptor antagonists may reduce craving and thus diminish engagement in addictive behaviors across conditions. We and others embarked on randomized clinical trials of opioid receptor antagonists, and several have shown the active drugs to be superior to placebo in randomized clinical trials. The findings have been mixed, but some positive results. These are results from one of the larger studies. So this was close to 200 individuals across multiple sites. And we observed that nalmefene was superior to placebo in the treatment of gambling disorder. And the 25 milligram per day dose, which is roughly equivalent to 50 milligrams per day of naltrexone, appeared to be the most efficacious and well tolerated. However, there was variability in treatment outcome even at this quote unquote best dose. And so we were interested in what were the factors that might relate prospectively to treatment outcome, ones that we could assess clinically. And what we found was that from a statistical perspective, the factor most strongly associated with a better outcome to the active medication, either nalmefene or naltrexone, we combined data from 2 trials, was a family history of alcoholism. And those who had that family history did better. And this is consistent with a role for naltrexone and opioid receptor antagonists in the treatment of alcohol use disorder. We also found that amongst the subjects who were receiving the higher doses of active drug, that gambling urges at treatment onset were associated with treatment outcome. So stronger gambling urges, better treatment outcome to the active drug. We did not see this relationship amongst the individuals receiving placebo, where outcome was most strongly associated with younger age. Now, mood disorders frequently co-occur with gambling disorder as well. And bipolar disorder shares both mood dysregulation and impaired impulse control. And so we and others at Yale were interested in understanding the neural correlates of cognitive control in individuals with gambling disorder and individuals with bipolar disorder. And what we found was that the groups differed from control subjects during a cognitive control task by showing relatively blunted activation of the ventral medial prefrontal cortex. So it suggested that perhaps some of the treatments for bipolar disorder might be helpful for people with gambling disorder. And what's shown here is a randomized clinical trial, placebo-controlled, of lithium versus placebo in the treatment of individuals with gambling disorder and what was termed bipolar spectrum behaviors. And this is largely a group with bipolar II disorder. And what was found in this study was that lithium was superior to placebo with respect to reducing both problem gambling severity and mania ratings over time in a somewhat parallel fashion, again, resonating back to the anxiety disorder study. Now, there have been other medication groups that have been tested based on preclinical and other data. One of these is the nutraceutical N-acetylcysteine, and John Grant and colleagues found that the active nutraceutical as compared to placebo was superior during a double-blind discontinuation phase. And this is a relatively well-tolerated over-the-counter amino acid supplement that can be used in the treatment of individuals with gambling disorder. Now, given its data suggesting a role in substance use disorders, we investigated the utility of N-acetylcysteine in conjunction with behavioral therapy, both for gambling and for tobacco use in individuals with dual gambling and tobacco use disorders. And what we found was that there was some benefit in both domains. There was a more rapid smoking cessation response with the N-acetylcysteine and a improved follow-up gambling treatment outcome in the sample that was observed in the N-acetylcysteine arm. Now, there are preliminary data for other types of medications, including the COMT inhibitor tolcapone. And we've reviewed the pharmacotherapies going back now several years. And based on the existing data, we've proposed a pharmacotherapy algorithm that is based on initially whether people might be interested in taking a medication or not. And if they're not interested in taking a medication, perhaps they're willing to take a nutraceutical. And then using dual disorders as a branching arm in the decision-making, branching point in the decision-making tree as to medication selection. So there have been debates about transdiagnostic versus diagnostic groupings and their utility. And some transdiagnostic considerations might be with respect to compulsivity. So this has been linked to gambling and other addictive disorders. And we conducted a latent class analysis using the Vietnam era twin registry data and identified 4 latent classes of obsessive compulsive features, a high obsessive compulsive group across the board, a low obsessive compulsive group across the board, and then 2 that differed according to scoring high in specific domains. One class on rituals and symmetry, and another on rituals, germs, and contamination. And when we looked at the relationship with gambling disorder, either at a diagnostic threshold or a subdiagnostic threshold, we found that all 3 of these classes of the elevated obsessive compulsive features were associated with gambling disorder. And then we also could estimate the genetic and environmental contributions, and found that the overlap was largely due to shared genetic contributions. So we've been interested in understanding both impulsivity and compulsivity as it relates to treatment outcomes. And we found that self-reported impulsivity have both been related to problem gambling severity at treatment onset. But self-reported changes in impulsivity correlated with changes in problem gambling severity with treatment, but not with changes in self-reported compulsivity. We've also looked at behavioral measures of impulsivity and compulsivity, in this case in an open label trial of memantine, and found that at baseline, problem gambling severity, or the gambling disorder group, showed elevated compulsivity and impulsivity with reductions in both domains during treatment. So it seems like both behavioral and self-report measures of impulsivity and compulsivity are important to consider. So we've also been interested in understanding genetic contributions and how that some genetic differences might influence treatment outcomes. And this is a study out of John Grant's group looking at a COMT inhibitor and how a commonly occurring allelic variant of COMT that is related to enzymatic function might relate to treatment outcome. And what was observed was that indeed reductions in problem gambling severity were linked to the allelic variant, and also that the medication appeared to improve frontal parietal engagement during performance of a Tower of London task, an executive functioning task. So it suggests a mechanism for a treatment that might work well based on genetic differences. So we've also been interested in understanding the neural correlates of reward processing across disorders. So initially on the monetary incentive delay task, Daniel Hammer's group showed that individuals with alcohol use disorder showed blunted activation of the ventral striatum in anticipation of working for monetary reward. That was later replicated in a group from Germany. And subsequently, similar findings have been observed in individuals at risk for alcohol use disorder, those family history positive, as well as individuals with tobacco use disorder, gambling disorder, and binge eating disorder. And in studies where people have looked at a relationship between ventral striatal activation during this phase and impulsivity, there's been an inverse relationship observed. So the greater the blunting, the higher the impulsivity. Also, this blunted ventral striatal activation during the anticipation phase appears to cut across substance use disorders, gambling disorder, as well as internet gaming disorder. And when we've looked at changes during treatment, we found that in this case, in adolescent smokers, that this relative decrease was quote unquote normalized, or there was an increase in activation following treatment as compared to prior to treatment. And we've also seen this in individuals with cocaine use disorder, where after treatment, there is a more robust activation of the ventral striatum during the anticipatory phase of reward processing. So we hope that we will be able to understand whether this may extend to other co-occurring and behavioral addictions. So I would like to summarize by saying, although we've made a significant progress in understanding the neurobiology and treatment of gambling disorder and dual disorders, there is still much that we need to understand, and that dual disorders represent an important clinical consideration in the treatment of individuals with gambling disorder, and we should continue to conduct research so that we may continue to better policy prevention and treatment efforts. So I'd like to thank a large number of individuals who contributed to this work, and to thank the funding agencies, as well as to thank you all for your attention.
Oui, Monsieur Bundani.
We are here. So, Mr. Peanuts, please.
Yeah. Thank you very much, Mark, for this excellent update. And your shows was how many is complex this conduct and this disorder. And without wasting time, I give the floor to my friend Ikro to introduce the next speaker. We can later, and we can discuss more about your excellent presentation. Ikro, please.
Yes, thank you. The next presenter is Dr. Ken Winters. Dr. Winters is a senior scientist at the Oregon Research Institute and adjunct faculty in the Department of Psychology, University of Minnesota. Dr. Winters, in the Department of Psychiatry at the University of Minnesota, founded and directed the Center for Adolescent Substance Abuse Research for 25 years. He has received numerous research grants from the National Institute of Health and various foundations, and has published over 135 peer-reviewed articles during a 30 years period. The title of his presentation is Adolescent Brain Development, Drug Abuse, and Mental Health. Please, Dr. Winters.
Thank you very much for the introduction. Hello, everyone. I want to extend my thanks to Mehdi and the rest of the conference planners for this wonderful opportunity. You can see my email on the first slide, so feel free if you want to follow up with a question, or if I can send you any resources that I talk about. As you can see, I'm going to try to, in a short amount of time, discuss the fairly complex intersection of adolescent brain development, risk for drug abuse, and mental health. I do not have any professional disclosures to report. I do have a personal disclosure. I hope to avoid a reaction from you that was once voiced by the famous Italian-American physicist, Enrico Fermi, who he had heard a lecture, and after he attended the seminar, he said, "Before I came here, I was confused about this subject. Having listened to your lecture, I am still confused, but on a higher level." So hoping you're not going to be confused on a higher level, but more informed on a higher level. Briefly, some easy to access resources before I get into the heart of the talk. UNICEF has an interesting one on adolescent brain development. It has a lot of graphics and pictures and images that help present the information. I think this is particularly good for youngsters and parents. Could be used in any prevention or education format. I'm particularly impressed with Harvard's Center on the Developing Child. They have a new podcast series called The Brain Architects. And it provides a nice, understandable way to think about how science is increasing our knowledge about how brains are built and what makes them strong and what can be a risk for a deleterious impact on brain development. I searched for a good TED Talk, and I thought Sarah Jane Blakemore's was the best. It's about 12 to 15 minutes, but she does an excellent job speaking, again, on a very understandable level about adolescent brain development and how it affects behavior. Useful information for teenagers, parents, and clinicians. So here are the 4 topics I'm going to address. A brief overview on brain development, and then the heart of the talk is talking about brain development with respect to drug abuse, with respect to mental health, and then discussions about implications for service providers, for treatment providers. One important slide here, a reminder that it's pretty complex to talk about direct links between brain functions and human behavior. So I think of that warning sign I have in the bottom left-hand corner quite often throughout my talk. And so we always have to be cautious about not over-interpreting when we're studying brain function, brain structure, and how that might impact adolescent or adult behavior. Also, my spotlight here in this short amount of time is going to be mostly on neurodevelopment, but this does not diminish the impact of environment and social determinants. I do bring it up a little bit with respect to mental health, but of course it's a complex interaction between biology and environment when we talk about human behavior, including adolescent development. There are 3 major points for my talk, so I thought I'd give you the primary conclusions of my talks, and then I'll unfold the details for each of them. So one main point is that maturation of the adolescent brain likely contributes to behaviors that are characteristic of this developmental period. Perhaps not a news bulletin if you studied adolescence, but I think it's more than just social determinants. I think this maturation can inform our understanding of risk for substance use disorders and other behavioral disorders. And this information can be leveraged for you when you're working with teenagers, whether you're in a prevention or a treatment arena, whether you're working directly with teenagers or with parents. This science on brain development, I think, can be useful tools in your toolbox. In that light, I'm going to highlight 5 ways in which you can use this science. Teaching young people about brain development, the importance of treating behavioral disorders as early as possible, the value of using evidence-based treatment programs and practices. I'm going to make my pitch that you, when working with young people, do what you can to increase what I'm calling their cannabis and vaping IQ. These are 2 more recent threats in the drug abuse arena for young people, and I think there's a lot of myths that they have about cannabis use and vaping. And then a focus on the importance of educating parents. So I'll return to those 5 later on. Okay, topic number 1. Briefly, an overview of brain development. There are 2 main principles I want to emphasize. These are probably principles you're well aware of. There's now, plenty of, I think, good neuroscience to indicate that brain maturation continues throughout adolescence. And in many instances, in many ways, the structure and function matures at approximately age 20 to 25, although there's plenty of changes in the brain throughout the lifespan. But major developmental processes continue significantly through adolescence and flatten out around age 25. The second major principle is that the way the brain develops is not uniform, but it occurs through an enveloping or back to front type process where the so-called go systems, or I'll call it the accelerator systems of the brain, they are developing faster than the brake systems. And this is a time-lapse representation of that process where neuroimaging is synthesized here from ages 5 to 20. As the colors are going blue, that's synaptic pruning, and it's an enveloping or somewhat back to front process where the limbic regions are developing a little, they're maturing a little earlier, and those regions have more to do with emotion and motivation, whereas the more frontal part of the brain, more having to do with executive functions and judgment, mature a little later. Developmental psychologists have weighed in on this to try to draw some links between that neurodevelopment and adolescent behavior. This is a list that we compiled with my colleagues, looking at that literature, seeing where there was some consensus. So a warning, this is trying to make some bridges between neurodevelopment and behavior, which you have to do cautiously. But some themes that emerged. Adolescence, it looks like to be a time when there's a high preference for physical activity, excitement, activity with peers, and novelty. Less than optimal control of emotions and consideration of negative consequences of risky behavior, and a greater tendency to be very attentive to social information and to take risks. So these behaviors are part of human nature, but the notion is that during adolescence, they might have more prominence. They might have more of a role in choices a teenager makes, values they hold, decisions they make, whether it's short-term or long-term decisions. The last one, taking risk, is an interesting one. Not all risk is unhealthy. Some of it can be very important for growth and development. And there's a notion that risk-taking is distributed as a trait on a basically bell-shaped curve type distribution, where more people are sort of average risk takers, and then you have a small percent are very at the low end and a small percent at the high end. The notion is, though, during adolescence, you're taking risk a little bit higher than perhaps what your set point is. So if you're an average risk taker, and I think that's an example of myself, I don't have any great stories to tell you of how my teenage brain and my limbic system ran amok and I got in all kinds of trouble. That would probably make sense because I maybe just showed a little bit above average or above my set point for risk taking when I was a teenager. But if you are working with people who have a tendency for high risk taking, maybe problems with impulse control, then during adolescence, those traits underlying that characteristic may lead to problems. I kiddingly tell people, if I had a chance to interview Wall Street hedge fund managers, I bet they might have some interesting stories about their adolescence. I have an expectation that if you're a successful hedge fund manager on Wall Street, you probably are a risk taker. You probably have been most of your life. You've learned how to use it for adaptive purposes, but during your teen years, it might have created some issues. So we took our list and then asked the question, well, of these features, these 8 features, which ones might, if they particularly are shown in excessive ways, create a risk for drug abuse or mental or behavioral problems? And we labeled 7 out of the 8. We didn't label physical activity, but we looked at these and thought, well, yeah, if things got out of hand in terms of being pulled in by peers, not considering negative consequences, poor emotion control, etc., these behaviors could contribute to unhealthy lifestyles, choices, and behaviors. But on the other hand, they're not all negative. So we also looked at the list, and our staff, we discussed, so what might be promoters of health and personal growth? And so we chose these 5: physical activity, excitement, activities with peers, novelty, and taking risk. So some of these traits, you could make a case, are things to embrace, encourage in a limited and healthy way, because they may promote adolescent health. So let's talk about the intersection of the developing brain and drug abuse. On one level, one could make a case that adolescence is a risk period, and perhaps brain development underlies this risk, given that, at least in westernized countries, the drug use starts during adolescence and it likely peaks during the late and young adult youth years. And so for most westernized individuals, the odds are you use drugs at the highest level when you were during your youth years, when you were the youngest. So at that 10,000 feet level, it's epidemiological based data, you can make a case that there is a significant risk when you look at young people and drug abuse. It also is an issue when it comes to developing a later addiction. So this shows a comparison of alcohol and marijuana, and it compares the age at starting using the drug as a function of then when you later developed a dependence. And you can see that the later you wait before you start using both alcohol and marijuana, the lower the probability of developing a later problem. The alcohol risk is higher than the marijuana risk, but you can see the pattern the same. Is it just age of onset? Of course not. There's many other factors. If I showed these bars for those that had a family history of substance use disorder, the bars would be higher. If I showed the bars of if you did not have family history, all the bars would be lower. And there's other risk factors, of course, that play into it. But age of onset's an important one, and that could set in motion certain neurological factors that add that risk. More on that in a bit. So since alcohol and marijuana are two of the most prevalent drugs used by teenagers, I'm going to just focus on two studies that look at these drugs with a more microscopic view and how they might impact development. Ruan published an interesting study because they did two things. They first had longitudinal design and they had neuroimaging data. So collecting data at 14, 16, and 19, and during those timeframes measured alcohol use and categorized individuals that were binge drinkers, either at the moderate or severe level, and then also had neuroimaging and personality data. And the bottom line of the findings was, although it's based on small samples, so worthy of replication, but from the neuroimaging data set, for those that had the heaviest binge drinking pattern, there was a disruption in the maturation of frontal connectivity. And the personality data also showed, I'd call it a negative finding. Those that were the heaviest binge drinkers showed or reported a slower developmental improvement in impulse control. Of course, the two could be related. Neuroimaging findings could reflect an underlying neurological issue because of the binge drinking, and that, of course, could manifest as poorer impulse control. A way to look at the impact of marijuana in youth. There's a lot of ways I could discuss this. I thought I would highlight the literature review by Volkov, director of NIDA, that was published in 2014. In that literature's review, they identified where there was some evidence of a link between chronic cannabis use and health impacts. And they identified 8 health effects. And there's the 8 there. And they also categorized each as to the extent to which there's either low, medium, or high level of confidence of linking cannabis use to the health impact. So lung cancer gets in the low level of confidence category. In the medium level are these 3, and in the high level of confidence are those 4 you see there. I've marked altered brain development relevant to our current topic. That went in the medium level of confidence category. The one caveat that they mention in that is that because much of the existing data that was available to look at back then was likely based on use of marijuana that had much lower potency than what's currently available. As many of you may know, the current strains of marijuana typically have more THC in it at much higher levels than in prior years. So it's a bit of a rear view mirror perspective when you're looking at impact of of cannabis use on health when the data is somewhat outdated. A little bit of a sidebar. I thought it'd be useful to talk about the impact of marijuana on adolescents and on an important cognitive variable, IQ. So many of you may know of this Dunedin study from New Zealand, longitudinal study of over 1,000 citizens. It's complicated design. With this graphic, I'm trying to make it pretty understandable. So there were a lot of assessment periods, but we're going to focus on the age 13 where they first measured IQ in the sample. And then if you go to the far right, also in red, age 38, the group was also given an IQ test again, of course, developmentally adjusted IQ. In between, in green, are the years in which they asked about marijuana use. So there were 4 time assessments at which marijuana use was asked. And at 18, if you were already someone who said, yes, I've used, they asked at what age did you start using? So in one of the publications, they looked at what was the change in IQ score from age 13 to 38 as a function of marijuana use. And in addition, as a function of how early in life did you start to use. And that is the data on this slide. It's a bit confusing. I'm just going to highlight with this call out where this major significant finding was that for those that in the sample that said they used cannabis before age 18 and they had a chronic use pattern, at least 3 times they were diagnosed as having a cannabis use disorder, either abuse or dependence, DSM-4. They had on average an 8-point IQ drop when age 13 to age 38 IQ scores were compared. On average, 8 points. So it was almost 1 standard deviation. Sorry, half standard deviation, because this is an IQ test that had 15 as a standard deviation points. So pretty significant. There was much less of a drop if you didn't use before age 18 and if you weren't a chronic user. So some moderating variables, but reflecting a negative impact. So I've made a case that adolescence is a risk period for drug use and that brain development might have a role. So why is that? There's several reasons that could be at play here. I'm going to focus on one of them that has to do with perhaps the brain's reward or pleasure center during adolescence is more susceptible to the effects of drugs. And this comes from the notion that one's dopamine system, the core neurotransmitter in our pleasure center, may react more acutely or more robustly to the effects of drugs than a mature brain. If that was the case, that could lead the teenager to be more sensitive to the initial effects of drugs, give you a sort of a bigger wow effect. It may increase your motivation to continue to use because it's very rewarding, and it may make it more difficult for you to reduce the use. You've got not only big rewards, but if we are correct that the teen brain is maybe not all that sensitive to negative consequences of one's behavior, that surely could weigh in on less of an interest of changing a behavior that might be quite unhealthy. So let's pivot and talk about developing brain and mental health. At a general level, it makes sense to research and think about this topic because so many behavioral and mental disorders have adolescent onset. Here's a list of many common ones. And there's a growing consensus that many of these might be at least greater or lesser extent due to alterations in neurodevelopment. Now, is that because of genetics? Could be. Is it because of somebody's using drugs early in life and that alters neurodevelopment? That could be. And of course, then there's the environment that could be at play. I thought for a moment I'd focus on the environment and pivot a bit away from biology. I thought a great quote from Anderson in publication 2003 that I think puts in perspective the potential impact of environment on the developing brain. Exposure to both positive and negative elements before adolescence can imprint on the final adult topography in a manner that differs from exposure to the same elements after adolescence. It does, with this quote, remind us of the relative impact of whether it's positive or negative on the developing brain compared to a mature brain. The salience of that impact can be much greater. Not all negative, but it's important to keep that in mind, that the salience and the impact can be much more significant. From Harvard's Developing Child website, I've got two quotes that further give us some insights into the potential of environment on the developing brain. The interaction between genetic predispositions and sustained stress-inducing experiences early in life can lay an unstable foundation for mental health that endures well into the adult years. So it's somewhat of a negative view of how the interaction between genetics and aversive environment surely can play a significant role in someone's mental health that may endure for quite some time. But the Harvard site reminds people of this. Some individuals demonstrate remarkable capacities to overcome the severe challenges of early persistent maltreatment, trauma, and emotional harm. There is resiliency, and people can overcome what look to be, very adverse experiences. Most potential mental health problems will not become mental health problems if we respond to them early. It's a great principle. Most mental health problems in young people don't have to become adult mental health problems or persistent mental health problems if there's appropriate response. And is response always formal treatment? I'd make a case, not necessarily. It surely can happen in the home and in the community. A couple studies about looking at experiences in brain development. One is right here that looks at how early experiences can have a positive impact. In this studied preschool children and looked at the sensitivity of early maternal support, and then looked at hippocampus volume and emotional regulation. So the good news was that there was a nice relationship. The more maternal support in that youngster, in that child, there was more or greater hippocampus volume. And how did that translate to behavior? That led to better memory scores, which is logical, hippocampus associated with memory, but it also showed an improved or more stable emotional regulation. So that it had more than just a memory impact. It looked like it might have an important impact on how somebody copes with stress and in their environment, showing suitable or healthy emotional control. Well, one in the negative direction, looking at stress and how it can affect downstream biology and behavior. So this looked at a sample of infants who were, had to deal with a lot of stress. And then they were able to longitudinally follow and look at particular developmental changes. And then unfortunately, the negative effects were that the greater stress experienced during infancy led to more hormonal changes during the teen years, and also showed, compared to the low stress group, more abnormal development of connections between regions of the brain that control fear and stress responses. So that latter one would suggest that group would have a tougher time dealing with future stress. But it's not fate, of course. One has to keep in mind that all kinds of negative impacts in early life can be altered with favorable experiences, including formal treatment, and as one study, of course, I just showed, maternal support, family connectivity, etc. I'm going to pivot back to cannabis and talk about a study that looked at the potential impact of cannabis use on mental disorders. So Christine Miller reviewed this literature and published it in 2018. Kind of a complicated chart here. But she identified 5 disorders, that's the 5 rows, for which there was a sufficient amount of evidence that attempted to look at the link between cannabis use and these disorders: schizophrenia, bipolar, anxiety, depressive, and risk of suicide. And then she discussed the strength of the data, whether it was cross-sectional or longitudinal. Now, I put pluses to represent how strong she said was the data. So for schizophrenia, she said the data were quite strong, both cross-sectionally and longitudinally, of the link between cannabis and schizophrenia. Then you can see where there's single pluses, that means it's moderate amount of data suggesting a link. And if there's no plus in the box, she said there was very insufficient or no data at all. Well, anyway, you can see based on my little coding scheme, the strongest evidence is for schizophrenia as a link between cannabis and mental health. Why did I put 3 disorders in a yellow box? These were the disorders in which she said, if you just looked at adolescent onset cannabis use, you found a stronger association as opposed to later use or adult onset use of cannabis. So I'm just highlighting for you that when you do look at some of the links between drug use and mental health, sometimes you get a greater risk factor or a stronger risk when you have individuals that have used or started to use during their adolescent years. Okay, to round out my implication for prevention, treatment, providers, educators. You might remember way back 20, 25 minutes ago, there were 5 principles I was going to emphasize. One of them is the idea of teaching young people about brain development and its importance for health and personal growth. I think young people are interested in this brain science, and it can be of value to teach them how to use that for their benefit, as well as to be careful and not to let that development be damaged or affected in a negative way by decisions and experiences, including drug use. An elaboration of that would be to remind young people that it can be sometimes difficult to make good decisions, because sometimes the teen brain isn't primed to be thoughtful, but to teach teenagers how to take good risks, how to have skills, what I call on second thought, that is basically skills to resist impulses or immediate impulses, to learn how to delay gratification, and the importance of not letting peer influences, which can be a problem for the adolescent brain, contribute to making poor decisions and getting into trouble. Second principle, perhaps a no-brainer: the earlier the treatment, the better across the board for disorders. Now, the slide to the right is just focusing on treatment for substance use disorders, but Michael Dennis and his team have shown how the earlier the treatment for substance use disorder, the more likely you are to achieve a good outcome. Defined here as 1 or more years of abstinence. And the blue line represents the most favorable, and that shows those individuals that within the first 9 years, somewhere in the first 9 years of having the first symptom of a drug problem, they got treatment. You can see the path to getting that abstinence milestone was much faster than the red line, which would be the worst case, that those folks didn't get treatment until 20 or more years after they had their first symptom. Using evidence-based treatment, I think, can optimize effectiveness. Summaries of evidence-based are listed here. These are very accessible, either literature reviews or reports. The bottom line for young people, there's starting to be a consensus that motivational enhancement therapy, cognitive behavior therapy, and family therapy, or combinations of those 3, are very strong to address the wide range of adolescent problems. And there's plenty of developing literature for the value of pharmacotherapy. I won't go down that road with you today, but as many of you know, there's a vast literature on an effective pharmacotherapy for ADHD, and surely emerging evidence on its use for adolescent depression and anxiety disorders. I mentioned I call them the two recent threats for adolescent substance use, cannabis and vaping. So a call out to increase your adolescents' IQ on these two topics. I've just given you two sources here if you want to develop or use exercises and quizzes about myths of cannabis or myths on vaping, getting young people to think about it and realize that it's perhaps not as safe as they may think or as social media may lead him or her to believe. And then my last is working with parents. One thing we do in teaching parents about brain development is we give them this little exercise using the letters from the word parent. Each letter stands for a key principle we want parents to try to learn or advance, to have in their toolbox. And we get parents to talk about what it would take to promote each of these principles, examples they might have. Feel free to use this if you like it. And each of them either taps directly brain development or just really good principles of good parenting. And we also point parents to some user-friendly websites. I have 3 of them here. Number 1 is the one from Mentor International Foundation, an excellent group, and they've developed a resource for parents. Number 2 is NIDA's resource. It's NIDA for teens, but it has information for both teens and parents. And then some of you may know about drugfree.org. This site now has developed prevention, intervention, and treatment resources, not just a prevention resource anymore. And thank you for your time. I hope you got some information from this, and I look forward to some discussion.
Mr. Romanieri is for you, please, and Mr. Maggi.
Thank you so much, Ken, for your excellent presentation. Yeah. I give now the floor to Professor Ifrah Kaminer, who shall speak about dual diagnosis of youth substance use disorder and depression. Professor Kaminer is professor of psychiatry and pediatrics, Alcohol Research Center, and Injury Prevention Center at the University of Connecticut School of Medicine in Farmington, Connecticut, United States. He wrote a lot of books and more than 200 articles. And I want to stress merely about the last book we wrote with our friend Ken Winters, The Clinical Manual of Youth Addictive Disorders, a very interesting book, and his updates about all what is related with youth and drug disorders. And I give you welcome, Ifrah. I give you the floor. Thank you, Ifrah.
All right. I'm waiting for the slides to appear. Anyway, good evening, everyone, and to our Moroccan hosts, Masao al-Khiri, Buona noche, buena serata, bonsoir, to all the people that I do and I don't see right now. First and foremost, I'm glad that all of you are, even though you're only virtually here, that you're healthy. I saw Ikro, I saw Ken, my friend, nice bird. And I can almost smell the Moroccan tagine and the khreime and the harira soup that I was hoping for, but inshallah we'll do it. diagnosis with particular let's go. I'm going to talk about dual diagnosis of youth substance use disorders with co-occurring depression. Due to the short, term of the presentation, I will not address suicide, which I usually do without just a couple of comments. And here's my disclaimer. I'd like to thank my collaborator because I'm going to present to you also some updated info that part of it has not been published yet. So that might be interesting. And indeed, I need to convey that I do receive royalties for authors and edited books, including the one that I co-edited with my friend and colleague, Ken Winters. Next, please. Okay, so this is what a typical flyer or brochure looks like in our studies. And this is a study that we conducted on adolescents age 13 to 18, but we also extended it to college students up to age 21. And next, please. Now, in order to get updates, this is the most updated information from the United States, from the NSDUH data. And as you can see, even if there were actually figures here from previous years, there is a continued constant increase in the prevalence of depressive disorders in youth and in emerging adults 18 to 25. As a matter of fact, if you would have looked at data from the 90s, you would have seen that the percentage hovers between 8 and 9%. So there's unfortunately a continued increase, and this is even pre-corona and pre some other kind of developments. What is most important for us as dual diagnosis interest group is that those who have a major depressive episode, almost a third of them were using substances as compared to almost a third compared to those who did not have MDE. Next, please. So it is also important to understand, and unfortunately not a lot of people pay attention to it when we address the dichotomous binary approach, the diagnostic one versus the dimensional approach, that sub-threshold symptoms need to be recognized and need to be addressed. Unfortunately, in the United States health system, you don't get reimbursed, get money for people who do not meet the criteria. However, if in order to get the diagnosis of depression, according to DSM, you need to meet, the adolescent need to meet 5 symptoms, what happens if the adolescent meets 4, 3, or even 2? We have realized, and you'll see it in our study, that actually the severity of this, the score itself was more important than the number of symptoms. Furthermore, not everybody who is sub-threshold or underdiagnosed will continue to progress to full-fledged depression, although some will. So as a matter of fact, this is what, was coined in the past, the term of orphan diagnosis, meaning that you don't know exactly where to put it. This is some kind of an orphan, but it cannot be underestimated. Next, please. So as you can see, the odds ratio or conduct disorder, depression, and anxiety, and as Ken Winters mentioned, it's the highest among those with co-occurring psychotic disorder spectrum, such as bipolar disorder and schizophrenia. Most studies of depression, you will see the odds ratio is give or take 2. Next, please. There's a systematic review here published in JAMA last year that shows you the gravity, how serious it is to have co-occurring disorders. And as you can see, suicidal ideation odds ratio is high, but what is really a major concern is the suicide attempts. It's more than 3. So it is pretty clear that the use of drugs, including cannabis by adolescents, may increase the risk of depression and also may increase the risk of suicidal behavior. Next, please. Just a second, I have something here on my screen. Okay, that's much better. Now, oops, I lost the show. My McAfee tries to sell me something. No, I don't want to buy it. Hold on a sec, people. I'll be back, hopefully. Okay, I'm back. Thank you. Next, please. Okay. Depression and cannabis use among adults over age 20 just was published like a couple of weeks ago. And this is really an important study because it shows you that emerging adults, many of them who have mood and anxiety disorders, report cannabis use to self-medicate, which increases the severity of the depressive and anxiety episode, and else actually shorten the remission as well. And this is, of course, not surprising, associated with increase in near-daily cannabis use. So we need to deal with a lot of fake news in this world, and one of them is the public view of cannabis as effectively beneficial for anything, from flat foot to whatever, and it is not beneficial for depression. And when I work with adolescents who are depressed, and they say, of course, that it makes them feel better, I just provide them with the data and said, this might be a temporary relief that will get worse later. So definitely this kind of self-medication approach clinically and long-term is unjustified. Next, please. Okay, another issue, there's a most recent study, systematic review by Nicola Black in the Lancet that shows, again, people were studying even just cannabinoids, including CBD and not just THC. There's definitely very scarce evidence to suggest that they will improve the symptoms. Of course, research should continue because we know that some cannabinoids might be helpful for the treatment of psychosis. I think that somebody would address it tomorrow. I won't get into it, but bottom line, be very careful because what is being sold in the street, including in dispensaries, including everywhere, is not always what you want to buy. So there's no quality control over what is being sold. And bottom line, it causes more harm than benefit. Next, please. So we get into the chicken and the egg controversy. What came first? Next, please. So I'll go quickly over some issues that you're familiar with, but I'll just kind of try to focus on a couple of issues. We have a secondary substance use model, self-medication. You know, it has a great face validity, but not highly supported in research. Secondary psychopathology disease model. And of course, there's bidirectional effect on each other and a rebound effect that is associated with the allostatic model that I will address in the next slide. It is clearly very important to address the common factors shared liability model, meaning that you have like a trunk of a tree and the branches that came up of this tree, they are all problematic and dysfunctional in many ways. We call it, quote unquote, the family from hell. I've never seen an adolescent whose only problem is substance use disorder. There are 17–80% psychological and psychiatric problem on axis 1 and axis 2. There are academic problems, there are family problems, there are legal problems. It's and or, and we need to address all of them in case management approach, which is kind of difficult in terms of resources. Of course, I need also to mention could be unrelatedness model, some co-probability of otherwise unrelated disorder, but that's probably unlikely. Next, please. The allostatic hypothesis is extremely important for dual diagnosis. It actually, George Koob, the director of NIAAA, I would say addition or development of the rebound effect. So the idea is that there are some areas in the brain that become sensitized, thank you, and there are some kind of incentive salience to substance use related behavior. The substance use does not do good work in self-medication for long term, so they need to increase the dosage. because of development of tolerance. If they add a psychiatric disorder before, which is highly likely, 3 out of 4 cases, according to several large epidemiological studies, then for a while it works. Then the depression or the anxiety becomes more severe. Then they increase the dosage of what they're using. It's what we call the slippery slope. And they may move to other drugs, including, opioids that unfortunately, and cocaine, that we know the damage and the overdose, or what we call fatal drug intoxication, is quite huge. Actually, it's not for this presentation, but I've just completed a study on suicidal behavior among adolescents who OD, and this is a very interesting literature. But the bottom line is the dual diagnosis is highly prevalent among those who are ODing. And as you can see from the citation of Olson, progression to non-cannabis substance use disorder is anticipated and expended effort for relief. There is a paper I just saw this morning. I haven't even read it completely. Published in what was it published? Honestly, I saw it like an hour before I got online, that in a peer-reviewed journal that shows very clear association between the use of cannabis and the use of opioids. Okay, let's move on. Thank you. So what happened in adolescents? We have a study that came out from the Netherlands that reviewed and meta-analysis of depression in adolescents. Again, the odds ratio is about 2. It's pretty clear the mental health disorders are a risk factor for substance use disorder, and it works both ways. There is the European group on the Genomic Consortium also talked about shared liability, which I will address in the next slide as well. And we even know from relatively a study done by Shirley Hill more than 20 years ago that children of alcoholics are at increased risk of developing other disorders, and it's showing cross-disorder transfer. So there's no doubt about it. The dual diagnosis is the rule rather than the exception. Next, please. So cannabis use and MDD, there's a study from Agrawal published in The Lancet that showed within monozygotic twins that pair with heavy cannabis use significantly more likely to meet criteria for MDD than the identical twin who either never used cannabis or used it less frequently. Again, because I'm working with adolescents, very passionate about it, maybe even a little zealous about it, it is pretty clear that this is not a good drug to use, and definitely not at a very early onset, because we know that, and you saw the great presentation of Ken Winters, that if cannabis use disorder among adults develops in 9%, 1 out of 11, in adolescents, it develops 1 out of 6. And I'm concerned that the increase in the strength of the THC might even make this percentage even higher. So you see some data from the NSDUH, a 10 years review published last year by Cara. There is a clear dose response. The OR is not very strong, but the significance is. And we definitely need to address the dose response aspects that are definitely evident in cannabis use risk of psychosis, particularly those who use what they call in the UK skunk, which is 10% THC. Next, please. Next. So why we cannot further ignore substance use in patients with mental illness? You have overlapping developmental, environmental, and genetic vulnerabilities. Drugs can trigger mental disorders or those who are vulnerable and exacerbate that. Patients with mental illness are at greater risk for SUD, and so on and so forth, including increase in morbidity, mortality, and you can see that even in a 42-year study follow-up, all these disorders that are mentioned here are associated with the use of drugs and with premature mortality. Next, please. So what are the negative consequences, depression comorbidity in youth per se? You have, to summarize, elevated risk for suicide, greater treatment attrition and poor outcome, and poor overall quality of life, including social competence, mental, physical health. And not to mention, this is a curse on the next generation. It's the sins of the fathers, as we say, and the mothers, that if parents are using cannabis, there are some epigenetic implications as well as other drugs. I won't get into it, but this is absolutely a major issue for parents to say, oh, no big deal, we are using it, the kids are not using it. There's also secondhand smoking research right now on cannabis as well, with some harmful outcomes. Next, please. So just quickly, one about suicide. The likelihood of suicide attempt increases by at least 2.5 with each additional psychiatric disorder. When you mix MDD and substance use disorder, the increase jumps to 10 or 14 times. A study published by the WHO a while ago, a multinational one, was pretty clear that very high rate of suicide cases were associated indeed with substance use disorder and with mood disorders and with disruptive disorders, which includes ADHD and conduct. Next, please. So we have a tale of two systems a la Dickens, that most adolescents receive separate substance use disorder treatment for medical and psychiatric services. Other people say we just treat mental health disorders. Some substance abuse facilities say we treat only substance use disorder, and basically we have very few programs that treat dually diagnosed adolescents. And I can tell you from New England, northeastern United States, where I am, there are very few programs for dually diagnosed adolescents, and a couple of them have already closed. So I'm really scratching my head with anxiety and despair, because I think that the system is not well equipped to provide resources for those facilities, and we will regret it. There are going to be some negative consequences. Next, please. So something very recent that came out from NIMH, as you can see, indeed treatment of depression per se or substance abuse per se definitely exist. However, treatment of dual diagnosis is so low, it's really depressing. I mean, talking about depression, to see that it's between 4 and 5% only. So it's not enough that a lot of adolescents do not get substance abuse treatment services, only about 10% of them. But when it comes to dual diagnosis, it's a major issue. I don't have time to talk about it. I have some speculations. I'm conducting a study on barriers for dual diagnosis. I have some partial outcome. I'll show you only one slide later, but hopefully in upcoming conferences, I'll be able to share it with you. The literature is almost non-existent on barriers to dual diagnosis, and in particularly in adolescents. We conducted an extensive literature review. Next, please. So here are the barriers. Some of them are the historical separation of substance abuse and mental health, as I mentioned, tendency to exclude youth with substance use disorders from clinics, or tendency to exclude kids with very severe depression or suicidal behavior, and they are really the ones who deserve high quality treatment. In the United States, the first line of defense are pediatricians that are supposed to see children and adolescents once a year, but many of them are not interested or are not trained in substance use disorder. So far from sight, far from mind, and there is definitely some developments in adolescent medicine, and there was the group that Ken Winters mentioned in Harvard, the people who developed some rating scales, but it's way far away from being satisfying. Next, please. So we conducted a study almost 20 years ago in 4 sites in the United States, the CYT study. This was the largest ever until now study for the treatment of adolescents with cannabis use disorder. N equals 600. My team was one of the sites, and because Connecticut is so small, up there we are actually swimming in the ocean where you see this red dot, but a lot of data came out of it. Next, please. And most recently, one of my colleagues who actually used to work at University of Connecticut, then at Yale, now is at Virginia Commonwealth, Albert Arias. We took a large data set from the CYT study that its focus was only on treatment of cannabis use disorder. However, there was evaluation of co-occurring disorders, but nobody just paid attention to it. So we decided to look at the data, to revisit it, and see what happens with those who had depressive symptoms or met criteria from MDD, and how it affected their outcome. So as you can see, 18% had met the full criteria of MDD, and about 70% had at least some symptoms. So in a nutshell, there was a significant linear decrease in depressive scores, even though the treatment was not specific to depression. And what is also interesting, that improvement in both symptoms was not correlated with type of treatment provided, and improvement in cannabis use was not significantly influenced by depression, severity at baseline, and vice versa. The article just came out last month online at the Journal of Substance Abuse Treatment. You're invited to read it. The statistics is above my pay raise, but it has been done very well, and it's really kind of interesting. Next, please. We've done some time lag analysis just to impress you, and we looked at within subject severity, and as you can see, there was improvement both in depression and both in cannabis use disorder. So the conclusion was that both cannabis use and depressive symptoms decreased concurrently following treatment of motivational enhancement or motivational interview, what you call, plus cognitive behavioral therapy, manuals that we have developed and also kept on developing for future studies for this study. And it's extremely important that providers would address this issue by providing adolescents with MET, CBT. I will get to the mechanism of behavior change that are very important to understand why they are supposedly helpful. Next, please. So the question would be, okay, what are the proposed mechanisms for symptoms change? I think it's a little bit ambitious to imagine that some kind of psychosocial intervention would be able to address compromised reward system, overactivated stress circuits, and dependence-induced reward dysregulation. Really, we need to be kind of humble, and we need to understand what's happened biologically and how does it affect neurobehavioral pathways. So one school of thought talks about dysfunctional reward processes, and the other one talked about self-efficacy as a possible mediator between depression and substance use. And indeed, next please, this is what we are doing in psychosocial intervention that includes cognitive behavioral therapy according to the manuals that we have developed. As then you can see this study published by Remo and Mark Myers in 2010 shows very clearly how self-efficacy is probably the most important psychosocial intervention that has impact on improvement of several behaviors. So even though at the CYT study, we treated only cannabis use disorder, there have been changes based on the study that we just published in depression scores because these disorders share common mechanism of behavioral change to develop, enhance them, and also to decrease them. So that's a very important take-home message. Next, please. I wanted to show this slide because, again, it's very important to understand, particularly people are relatively new to the field, when most of you are also teachers and mentors. There's no simple response, there are different subgroups of heterogeneous population or subpopulation that some of them are responding much faster and more efficiently or effectively, and others don't. And also it affects their not just immediate outcome, but maintenance of treatment gains and long-term outcomes. So I usually like to cite, the statement by George Bernard Shaw that said that for every complex problem, there is a simple solution, and it's always wrong. So we need definitely to look at different subgroups when we try to design treatment. And that's why, for example, again, I don't have much time to get into it today, is adaptive treatment is the way to go, to develop algorithm of treatment of psychosocial intervention, similarly to what we do with medications. Next, please. Okay, so unfortunately, I don't know, there are only two groups in the United States, in the big United States, that have done studies on comorbid depression. One is Paul Rody and his team. Now, Dr. Ken Winters is also among those people, the colleagues who work at the Oregon Research Institute. And the other one is the team that I've been working with and collaborating with the team from Duke, led by John Curry. So what Dr. Rody did, he actually was trying to look at the sequence and coordination when you treat youth with comorbid depression and SUD, and found actually that the order of treatment does not matter, whether you treat the substance use first or the depression later or vice versa. And again, the recommendation usually is to do it simultaneously. Next, please. This is just a slide kind of which is partly in development. So I'm sharing it with you. It will definitely be extended. This is something I've just done recently to show you that even recruitment pain to get adolescents into the study of dual diagnosis is so challenging and difficult. So on the left side, and both studies done in the same site by my team, so we didn't have any variability. So the first study of only substance use disorder of 2,052 referrals. As you can see, slowly how the number was reduced, how many was screened for eligibility, met eligibility, completed intake, began treatment. However, when you go to the core caring disorder treatment, oh my God, this is so bad. 212 that referrals inquiries, only 138 made it all the way to eligibility, meaning it's 35%, and trust me. And the next one, those who met eligibility, look at this depression, meaning decrease, but you can also call it depression, of another 57%. When they get to the complete intake and begin treatment, you don't see much difference. So trust me, I don't have it on this slide, but we're developing more slides. That it is statistically significant, and B, what we are really interested is also in a gender difference, because we know that when it comes to depression, it is more likely that females will have depression than males, and also we're looking at the dropout from the pre-treatment phase. So inshallah, we're going to meet another time, and I'll give you the sequel of this story. It's fascinating. You see on the bottom, it's pretty clear that dual diagnosis is more challenging even in referrals to treatment, in inclusion in treatment, and in inclusion in research. And this is a major issue that we as WADD people need to put some focus on it. Next, please. So adaptive treatment design, what happens is kind of quickly, everybody gets the same treatment. Then those who are not rapid responders, we randomize them into either additional aspect of treatment or different treatment. There's all kind of variability. Again, imagine an algorithm or decision tree when people do not respond to treatment of medication, which is much easier. Next, please. So this is the study we have conducted. We just finished. We are analyzing the data right now. It's actually will be very interesting. So everybody, everybody was dually diagnosed with depression and substance use disorder. The majority were cannabis use disorder, the minority alcohol use disorder, and some were actually combined. We provided them only with treatment for the drug use disorder, measured how much depression improved, and those whose depression have not improved, what we call rapid responder, we randomized it into 2 other conditions. Next, please. What we have found, actually, this is a study flowchart, by the way, that about 35% of those who were depressed, the depression improved to what we call non-clinical status. What does it mean? Next slide, please. It improved by 50% response reduction of the raw score according to this CDRS, the Child Depression Rating Scale, plus the SGI. And here I am kind of, in order to elaborate, and I know I'm sorry we're moving fast, but we have what have we defined as remission, a score of under 28, and recovery remission that lasts 2 months. Next, please. So as you can see, and again, this has not been published yet, so I'm happy to kind of share with you some new stuff. We are working on it. Early responders not only responded quicker, they actually maintained the treatment gains much longer and at a higher level than the other non-responders or poor responders that were given added treatment later on, because the early responders, we just watched them and reassess them at different follow-up points of time, at 12 weeks and then quarterly, every 3 months. We have not provided them with any treatment. So it shows you that those who respond early usually have a better prognosis, even though the other poor responders keep on getting some treatment. Next, please. And they do not, even though some of the poor responders improved later, they've not improved as well as those who were early responders, and the different approaches to treatment were not significant in terms of outcome. So what does it mean? It means that we need to look into the biological markers, the mediators and moderators of those who are likely to be early responders. And that's, again, bringing me back to the point that we need to look at this population as highly heterogeneous and treat subgroups. Here is a very nice model by Mark McGovern and his team in Florida that actually took the readiness for change of Prochaska and Di Clemente and looked at it in terms of dual diagnosis. I think it's kind of nice, and it's a busy slide, but I think it's very good for teaching. Next, please. What about pharmacotherapy? I listened to Dr. Potenza's presentation, and I'm so glad to see Mark in good shape. He's about 45 minutes from me, but now in Corona era, we don't see each other, so I was glad to see that he's alive and well. And he also mentioned NAC, and but so what we have found about NAC, there was a study that indeed it improved response in adolescents with cannabis use disorder. Study done by Kevin Gray from South Carolina. I guess it. I don't see any more slides. So in a nutshell, to finalize, again, those who want more information, you have my email. I'll be happy to share. Co-occurring depression is a serious disorder. It has implications not only for quality of life, but also for increased suicidal behavior. My team will continue to. Do I have any more slides? I know that I do, but maybe I ran out of time. Anybody from the hosts? So okay.
Yes, okay.
Well,
Next, please.
I think that, yeah, if it is possible to to conclude because
Okay,
we
sure,
have
yeah. Okay, I'm sorry about that because I know we, you know, yeah, not a problem, not a problem. Pas de problème, chers amis. So what we're going to do is basically, you know, hopefully continue in some future meetings and publications to introduce you to our studies. Okay, thank you so much. Thank you. We all set. Thank you.
Monsieur Mehdi, it's for you. Monsieur Mehdi, I think he has a problem. So, Mr. Romani, you can.
No, but if whatever, oui, if what,
Mr. Romani, it's for you.
il faut,
There is a Dr. Levrang.
no, it's Dr. Chairman, Nestor.
Ah, Nestor.
Nestor, yeah.
Okay, I'm going to try to share the presentation.
Yeah, I think there is no the need of a presentation for Nestor.
I'm trying to share the presentation. Sorry.
Scello la presentazione secondo. Dirlo background. صافي ودير راسك صافي.
Thank you. Hello, friends. Hello, everyone. Thank you to the organizer for this kind invitation to be here. Thank you, Mehdi, for to be part of this presidential program. Today, I'm going to talk about a new concept that is called precision medicine. In this case, is precision psychiatry, related to our field of dual disorders. Next, please. Okay, next, please. Related to this presentation, I don't have any conflict of interest. Next, please. These are the topics that I'll be addressing during this presentation. First, definition of the term dual disorders in neurosciences, dual disorders in precision psychiatry, and conclusions. Next, please. Next, please. Okay, dual disorder. We're all talking about dual disorder. What does this mean? This is a term used in the mental health field to refer to those patients who suffer from an addictive disorder and other mental disorders. They can occur simultaneously or, even more importantly, from the conceptual point of view, sequentially throughout their lifespan. And the old philosophical question, which came first, the chicken or the egg? I'm going to try to answer this question, at least in the field of dual disorder, during this presentation. Next, please. I'm going to talk about dual disorders in the clinical neuroscience field, in a perspective from evolutionary psychiatry, in some perspective of neurodevelopmental disorders, dual disorder genetic diseases, and finally, dual disorders and precision medicine. Next, please. Let us start with two statements. Nowadays, all mental functions, therefore all mental disorders, are based on the brain. Next, please. The second statement is the lack of sensitivity and reliability of the current diagnostic criteria of mental disorders make it difficult to include all different mental expression, mental symptoms, personality traits, or mental disorders in one single categorical diagnosis. Next, please. We need to conceptualize mental disorder as brain disorders, as the function of neural circuitry and of biological networks, going beyond conventional boundaries and using a transdiagnostic perspective. Next, please. This paper was published 4 years ago in the New England Journal of Medicine. It was signed by Nora Volkow, George Koob, and Tom McClellan, supporting the brain disease model of addiction. Next. Some of the key points of this essential paper are: only a minority of people who use drugs ultimately become addicted. In fact, the most severe phenotypic characteristic of addiction will develop in only approximately 10% of people exposed to addictive drugs. Why is this? The answer is in the precision medicine concept. Because susceptibility differs, because people differ in their vulnerability to various neurodevelopmental, genetic, and environmental factors. Next, please. This is the reason why nobody can choose to be addicted. Only the individual who has this susceptibility to being addicted becomes addicted. Next. Why are genes important in psychiatry? The simple answer is for the same reason that is very important in other areas of medicine or biology. Most human traits in clinical disorders have a substantial genetic component. Genes influence and encode mechanisms of disease. They provide objective insights into individual predisposition or risk. They may help contextualize the interacting environment, and there are potential tools that can be used for the discovery of the new treatments based on causation and pathogenesis. Next. One drunkard begets another, wrote the Greek philosopher. And we agree with him and with the scientific community that the general concept, that addiction runs in families. This concept is beyond dispute, wrote Nora Volkow. However, the addictive phenotype could remain hidden because the environmental factor may be protective. For example, the absence of exposure to drugs, even though a large genetic load may be present. We can think, for example, in Islamic countries, or probably in this country, Morocco, where the alcohol probably is very restricted. Next, please. Over the last decade, different neurobiological research has been proposed by researchers. Most of them with the focus on the brain reward system, on the dopaminergic brain reward system. But we know there are other factors. We know that all psychoactive substances with abuse potential bind to some endogenous system, such as endocannabinoid system, the opioid system, the cholinergic nicotinic system. Next. Next, please. How relevant are these systems? From an evolutionary perspective, they have evolved for individual and evolutionary survival of the species, not to get high, of course. Both addictive behaviors and other mental symptoms can be explained by an inherited and or acquired deficit in these systems and brain circuits. In fact, these systems and circuits seem to play a crucial role in all mental disorders. Next. These fundamental biological processes, when disrupted, can alter voluntary behavioral control, not just in drug addiction, but also in other related disorders. Next. Okay, the evolutionary perspective of mental disorder. We need to think with this perspective when we are thinking about dual disorder or all mental disorders. Next, please. From this perspective, from the evolutionary perspective, animals would benefit from a neural mechanism, circuitry, that supports an animal's ability to pursue natural rewards, such as water, food, or sex. However, these circuits are sometimes dysfunctional, leading to various types of disorders. Next. We know, as Professor Winter said, brain neurodevelopment is a long process, continuing into the 20s, with multiple steps, organized and highly dynamic, that is, genetically determined, epigenetically directed, and environmental influenced. Next. For example, in this slide, you can see the brain of children who had lived in an orphanage. Children with emotional deprivation versus control had less connectivity between amygdala and frontal cortex, proportional to time they spent in an orphanage. This could lead later in their life to facilitate or to develop heightened emotional reactivity and impaired cognitive control. After that, we call with different diagnostic categories. I would like to add something more. In Western countries, children who are living in orphanage probably they are having biological parents with mental disorders or probably dual disorders. This is the reason because we need to consider the genetic contribution. Next. I think we are now in conditions to answer the initial question, which came first, the chicken or the egg? Because from this perspective, from the neuroscience perspective, it is known that the brain presents changes long before mental disorders are diagnosed. These brain changes can occur with subthreshold symptoms that precede the onset of disease. For example, the substance use disorder or the first psychotic symptom, making this debate, the egg or chicken debate, irrelevant. Next, please. Okay, I'm going to talk about this new concept of precision medicine, or in our case, from the psychiatric precision concept. Next, please. Precision medicine or psychiatry. It has been defined as an emerging approach for treatment and prevention that takes into account each person's variability in genes, environmental, and lifestyle. The goals of precision medicine are to predict the individual vulnerability, achieve an accurate diagnosis, and result in the most efficient response to treatment for each individual patient. Next, please. Next, please. Okay, in this slide, you can see on the left side different colors. Each colors represent different individuals, for example, men or women. For example, different ethnicities, Asian, Caucasian, African people, or different personality traits, shy people, impulsive people. All of them in the treatment A are under the same treatment, psychopharmacological treatment or psychotherapeutic treatment, and the result will be very poor. We need to develop a new treatment, a new paradigm, and design a tailored approach with different subpopulation groups, and then probably the result will be much better. Next, please. As you can see, clinical trials do not consider individual differences. Next. We have introduced the concept of precision psychiatry in the field of dual disorders. Next, from this, next please. Next, please. From this paper, we have written that the diagnostic system has played a significant role in stifling the innovation needed to incorporate cutting-edge science from multiple areas into clinical research. If precision psychiatry is able to meet all expectations, psychiatry, including, of course, dual disorders, will change both quantitatively and qualitatively. Next, please. Next. Okay, this is an unusual slide in my presentation. In this slide, you can see a cup of coffee, a cup of strong espresso, and two different individuals, or if you prefer, two different brains. Next. You can question why some people drink coffee to be more awake and others to sleep better. The same coffee has different effects on different individuals. The same substance has different effects on different brains. It is the same for different kind of drugs. It's the same for tobacco, for alcohol, for opioids, cocaine, or cannabis, including gambling. Next, please. Another thing, findings do not support the idea that drugs from different drug classes produce similar subjective responses in most individuals. Rather, they indicate a drug of choice model, in which individuals may be susceptible to particular drug classes based on endophenotypes such as personality traits or other individual differences. Next, please. We are talking about endophenotype. We know that endophenotypes such as personality traits determine vulnerability or resilience to substance use disorder and, of course, other mental disorders. Next, please. For example, impulsivity predicted addiction to cocaine in highly impulsive rats, but not their addiction to heroin. Cocaine addicts tend to be more impulsive than heroin addicts, and heroin addicts are more anxious than cocaine addicts. Next, please. So, humans are unpredictable. Because of diversity, one man's meat is another man's poison. Due to the diversity in genotype and environment, the effects of substances are not the same among different individuals, including those a different sex. Next, please. We are moving from the old paradigm based on drug-induced neuroplasticity on the brain reward system, largely dominant in laboratory research. That this is the normal paradigm. If you are gaming so much, we are using so much cannabis, we are stimulating the BRS, the brain reward system, and probably we are leading or we are going to develop an addictive disorders. We are moving to a new one paradigm where compulsive drug use goes beyond simple reinforcement mechanism on the brain reward system. It's a paradigm where individual-centered approach that places individual variation at the focus of interest, recognizing the strong connection between addiction and other mental disorders, mental symptoms, or different personality traits. Next, please. To summarize. Next, please. Research approach to addiction have evolved to reflect the real world, have written by David Belin. Compulsive drug use goes beyond simple reinforcement mechanism. Research on dual disorders is going to identify distinctive endophenotypes and neurobehavioral mechanisms that predispose individuals to compulsive drug use. Next, please. The new paradigm of dual disorders based on precision psychiatry therefore tell us that we should treat the individual rather than the substance, as we have done so far. We need to rethink dual disorders in light of new evidence from neuroscience research. Next, please. This is the last slide, just to the future. Just as science has been continually advancing, the field of dual disorders has also been continually evolving with new findings that push the concept beyond the established views. We believe that new surprises await us in the future, when new data will replace the currently consolidated views in our field. Time will tell. Next, thank you so much. Next, please. The end. Next slide. Okay, I'm finished. Thank you so much for attention and for your time.
Yeah. Thank you, Nestor. What, Ikram?
No, Mehdi is from Morocco, the last speaker. So it's better that you introduce him.
Okay. Well, it's a pleasure to introduce my colleague and friend, Professor Jalal Toufiq. Jalal Toufiq is a professor of psychiatry. He is the director of the Psychiatric University Hospital Razi from Rabat Saleh, and he is the vice president of the International Control Board in Narcotics from the UN. And he worked a lot in this field of drug addiction and in psychiatry also. Today, he shall speak for us about the drug legislation, current status and challenge. Jalal, you have the floor.
Thank you, Professor Paez. Do you hear me?
Perfectly, yeah.
Okay.
Go ahead.
Good evening, everyone. Thank you so much for having me for this World Congress 2020. Very happy to be with you. One may ask why drugs legislation have to do with dual diagnosis. I think one of the main problems that, in fact, we did not recognize the dual diagnosis issue until really late, and I think it would have changed a lot of things back in 1961 when the conventions were developed and elaborated. But that's another story, and I think we need maybe to come back to that another day. So this is, for those who do not know Rabat, this is the city where I come from, where I'm sitting right now, and so is Mehdi Paez, just to share little slides with you. It's a beautiful city. 4 facts to start with. There will always be drug-seeking behavior in humans, and I think you all know that. And because of that, there will always be economic, or apart from that, is that there will always be economic benefits out of it. And therefore, there will always be trafficking, and that's part of human being greed. And as it is impossible to confine drugs to their region of origin, of course, it is an international issue. It cannot be a country issue. It cannot be a region issue. And that's why a legal framework will always be needed. And if you go back a little bit to, one comment, this presentation, of course, is about illicit drugs. It's about legislation, so it's not about alcohol, tobacco, or other behavioral addictions. Although some of the concepts I'll be talking about do apply to those situations, alcohol, tobacco, and behavioral addictions. Bit of history. You all know the 3 UN conventions, 1961, the Unique Convention, 1961, 1971, 1988. And back then, when the first UN Convention was developed, the main drugs were plant-based. And of course, we at the time we were living with the surge of injecting heroin and also the emergence of acid. And second convention, if you look at the second convention on narcotic drugs of 1961, what it does say at the preamble, the first sentence is, the parties concerned with the health and welfare of mankind. So the conventions are really about the health and welfare of mankind. If you look at the Article 4, and that's one of the major challenges in the single convention of 1961, is that the 4C says, subject to the provisions of the convention, exclusively to medical and scientific purposes, the production, the manufacture, the export, import, distribution of, trade in, use, and possession of drugs. And this is one of the main problems that's discussed on the, and that's put on the table internationally nowadays, especially for cannabis. If you look at Article 22 22 says whenever the prevailing conditions in the country or a territory of a party render the prohibition of the cultivation of the opium poppy, of course, the kokabash and blah, 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 in its opinion, for protecting the public health and welfare and preventing the diversion of drugs into the illicit traffic, the party concerned shall prohibit cultivation. So even when you think about cultivating cannabis for any other purpose than, of course, trafficking purpose or black market selling or whatever, you should always take into consideration the possibility of that being, of course, diverted towards traffic and towards illicit consumption. Article 28 says the following, the paragraph 3, the party shall adopt such measures as may be necessary to prevent the misuse of and illicit trafficking the lease of the cannabis plant. And that measure is, of course, mounting an agency of cannabis. So something that needs to regulate, something that needs to monitor, supervise, and control. The Convention on Psychotropic Substances of 1971, the preamble also says, the party has been concerned with the health and welfare of mankind. So this is a very important issue. And if you go downwards, you will see that these are exactly the same concerns we're feeling and we're expressing nowadays. Nothing has changed since then. So the question that are often asked regarding the current legislations are the following. Do the drug conventions commit governments to implement a prohibitionist regime? No, they don't. I'll skip the explanations. Do the conventions hinder the availability of controlled drugs for medical purposes? No, they don't. Do the conventions treat drug users as criminals who require punishment? Absolutely not. Do the conventions support unqualified interventions for prevention of drug use and treatment of drug dependence? They don't. Well, actually, it's quite the opposite. They emphasize really the necessity for state parties to adopt a science-based approach in prevention and treatment. Do the conventions support compulsory treatment? Absolutely not. Are the conventions against harm reduction strategies? No, that's clear. The conventions are not against harm reduction strategies when harm reduction is not carried out in isolation or as an alternative to demand reduction. Are the conventions against the use of controlled narcotic drugs in the treatment of drug dependence? No, absolutely not. Are the conventions against human rights? Absolutely not. So this is these are same fake ideas or fake perception or wrong perception that many people, especially in civil society, have. Do the conventions support the death penalty for drug-related crimes? Absolutely not. They promote exactly the opposite. So why do we need to consider updating the legislation if the conventions are right and adapted to nowadays? Well, because the common paradigms that were, of course, demand reduction, supply reduction, the split between demand reduction and supply reduction, the use policies, zero tolerance policies, abusers versus dealers versus traffickers, countries that are producers, transit of consumers, it's absolutely obsolete. It's becoming obsolete. The main objective of eliminating drug use and eradication of drug use, and we can, as we always hear in many countries, is becoming senseless and nonsense. And so that's the war on drugs. The situation is still worsening, and we can see it. I mean, if you see the 2020 NODC World Drug Report, you will see that the numbers are actually increasing. Even though the prevalences are quite stable for many drugs, and I'm saying quite stable because they're increasing in many countries. Well, it's not the case of amphetamines. It's not a kind of stimulants. It's not the case of cocaine in certain regions of the world. It's not a case of the NPSs. So what we're seeing is that the epidemiological situation, I'm sorry, I'm just gonna, there we go. There we go. The epidemiological situations are really different from a country to a country. The drug use does not concern only a few countries, but most countries, just because It's not evaluated, it's not studied, and it's not assessed in many countries, especially in our region. The types of substance and nature of use significantly differ from a country to a country and a community to community, even though cannabis is still, of course, the most used drug in the world. The traffic, production, distribution, markets, and related crimes adopt different paths, and you can see it now through emails, through mails, through regular mail, to express mail, through containers, etc., etc. So the new ways and new paths and new techniques. Cultivation, availability of drugs, cultural perception of use differ also from society to society. Increase of chemically designed drugs that we can see nowadays, especially with NPSs. All the countries are potentially producers, transit, or consumers. So we cannot have legislations that do not take into consideration the differences between countries, the differences in the way they use drugs, the way they assess drugs, the way they actually promote policies against drugs, and the way also they market, cultivate, produce drugs. We're shifting also from a focus on substances to focus on individuals. The convention cite drugs, they name drugs, and they talk about drugs, but they don't talk about individuals. They don't talk about vulnerable populations. They don't talk about subpopulations. They don't talk about the gender issues. They don't talk about aging people. They don't talk about dual diagnosed people. They don't talk about dual disorders. They don't talk about people having mental disorders and having drug use. So it's really a tricky situation. Drug policies and interventions are more and more based on science. They were not at the time. At the time where the conventions were developed and elaborated, very scarce data were available. The civil society is highly involved nowadays, more than any time else. Human rights are more and more on the table. Drugs are no longer the same. We're shifting. We're in the world where there are new drugs that are emerging and being developed. Trafficking operations and techniques are really changing too. When you see, for example, people delivering by using drones, to deliver drugs, to your doorstep. Internet is becoming a major platform for drug marketing and selling, darknet, of course. So the global drug market is really expanding, and it's much more complex than it was back in the 60s and the 70s. Multiple mixing and multiple substances is becoming the common pattern. Using new technologies, overlapping between legal and illegal markets. When you see, for example, prescribed opioids and opioids sold in the street. New substances emerging, and we were talking about this later. Increase the use of precursors and pre-precursors to develop designer drugs, and et cetera, et cetera. So the new drug user, it is not the, I'm sorry to say this, not to use the term, it's not the what we used to call the junkie of the 60s. The new drug user is something else. It's a totally different person. Of course, we still have the same patterns that we used to have in the 60s. Of course, we still have the same pattern of use that we used to have in the 70s in many countries. But the new drug user is someone different, using different techniques, using different drugs for different purposes and in different way. So all ages are concerned. New drugs, new psychoactive substances, new pace and new ways of obtaining drugs. You don't need to go around the corner and wait for a dealer to come. You don't need to call and then go and get caught by a policeman around the corner or any street that's known for selling drugs. You can have any drug you want at your door. The social media is multiplying. It has this multiplier effect on the way we see drugs and the way we deal with drugs and the way actually we consume drugs and the way we produce even drugs. The notion of the right to use, and you can see that this is an escalating idea of people putting on the table their right to use and their right to do whatever they want with their bodies and with their brain, with their mind. A major challenge around cannabis legalization, and you see that this is a very green wave that's, of course, taken over and being set in so many countries around the world. The right to cultural differences, and you can see it in the law in Jamaica about the ganja, in Colombia about the coca leaves. The issue of opioid abuse, those who are in North America, but not only in North America, and other countries also like Germany, they know exactly what I'm talking about. It tens of thousands of deaths in those countries. The right to information, that this is a new concept, the right to get informed about drugs, the right to get informed about why don't I have the right to use the drug? What are the effects on my brain? What's my freedom and the scope of my freedom if I don't want to take that drug for any purpose I want? So the right to treatment and rehabilitation. And now we see people with more, of course, they're more prone to ask about their treatment and the way they're being treated. And the right also to harm reduction interventions. So the new drug use also is a totally different pattern. You can order whatever type of drug you want for any circumstance. If you want to take an exam, it's a certain type of drug. When you're done with the exams, you want to relax. It's another type of drug. The new pattern now is it's a poly and multi-drug use. It's multiple drugs, and also it's really a successive types of drugs that the people are taking. You can order on the internet, on the darknet. That was not the case back then. Home delivery, mail delivery, drones. You can see how stimulants are expanding worldwide, especially not only in Southeast Asia, but also in Japan, in Oceania, and also in East Europe. Even though cannabis and cannabinoids are still getting a lot of hype, and you can see other types of drugs that are taken, the lead in certain regions, like tramadol in the Middle East, Captagon in the Middle East and in Egypt. Personal use and cultivation, that's really, when you see all this indoor cultivation in Europe, hundreds of hectares in major cities, in major urban areas in Europe. Also the access to pain relievers. And this is, people have the right to have access to pain relievers, but people in many cases and in many countries are abusing pain relievers, and especially opioids. You see, back then in 1961, we were talking about 129 drugs. And in 1971, 144 drugs. That's it. When you think about it, and that in 2018, there are almost 800 new psychoactive substances. You can see the difference. Even though the main core of NPSs is around 75, 76 drug, but still, it's totally different world. This is a new world with new phenomena of using drugs. Darknet. This is from the MCDDA. In November 2017, 62% of darknet use was for getting drugs. 77% for illicit drugs, 80% for drug-related chemicals, and 5% for pharmaceuticals. And of course, the other 38% concern other uses, firearms, explosives, and etc. I'm going to skip this. I'm going to the current challenges. So the challenges are new harmful substances, new trafficking routes and modes, the need to find the right balance between reduction in demand and eradication of supply. We're shifting paradigms. War on drugs and politics becoming pragmatic policies based on science. Focusing on the substance, we're focusing on the person. Single drug use is becoming multiple drug use. One drug use history is becoming changing drugs. Classic drugs, natural drugs, and plant-based drugs are becoming synthetic. We know nothing about them. There is we used to have quite good scientific knowledge about the classic drugs. We have poor scientific knowledge about the new drugs, and sometimes absolutely no treatment protocols. Very difficult to standardize, very difficult to put in place. total prohibition. Now we have a large harm reduction a policy, and of course even more greater tendency to put in place harm reduction in many countries, even in Africa. We used to focus on cultivation eradication. We were focusing on cultivation business promotion. We used to, of course, ban drugs and put taxes on drugs. Now we're actually making taxes from drugs. We're making money out of drugs. We used to have classic means of traffic. Now we have new means of traffic, internet, mail. The drugs used to be very hard to get. Now they're very easy to get. There used to be a hidden pattern of use. Now it's a public use, within the street. Tough sanctions becoming permissive approaches, and few data. Now we have more data. Not sufficient data, not enough, but still a very great effort in evaluating and monitoring the drug use. So we need to make those drug policies and conventions becoming more people-centered, more person-centered instead of substance-centered, with full respect of human rights. We need to set also comprehensive and balanced approaches that are based on scientific evidence and in which public health approach prevails. Whereas in the conventions, they were not necessarily fact-based laws, but they were politics-based laws most of the time. We need also to tackle the issue of the lack of human resources, crucial to run those policies. There's nothing in the conventions that stresses out the fact that we need human and qualified human resources. We talk about budgets, we talk about finance, but we don't talk about qualified human resources. So we need new legislations that are structured around the persons and populations, considering gender, minorities, vulnerabilities, etc. Monitoring and evaluation, I'm going to go fast. Nothing in the conventions that's really clear in terms of requesting monitoring and evaluation. Of course, there's so many paragraphs in alluding to the fact that we need to monitor the situation, we need to follow the situation, but not in a clear manner. So we need new legislation that focuses on the necessity to evaluate and monitor, and especially to share data within countries. Also, we need to take into consideration the rapid changes that require rapid also sharing, the pace of science, the pace of policies, the pace of implementation of policies and programs, the pace of evaluating the impact, the pace of adjusting the programs is not the same pace than before. With internet, things are getting really much quicker and much faster, and we need to adapt also our legislations. We also need legislations that are designed to specifically tackle the issue of NPSs. We need to put in place something stronger than just warning systems on precursors and pre-precursors, with strong information sharing that commit all the countries to really to do. The issue of availability and access to under control pain medications, even though it is written clearly in the conventions that people need to have this availability, people need to have access to drugs that are, of course, in favor of good health and in favor of treating people, but it's not specific. And we need something really specific about every medication, not only pain medication, but every medication that's under control. And if you look at the Convention of 1988, I think we also need to maybe come up with something a little bit different for benzodiazepines. So legislation about accessing the right to information, access to treatment as a basic human right. Alternative to prison and proportionality. This is, of course, well written in the conventions, but I think we need to come up with something stronger. When you see the masculine mass incarceration, masculine in the Philippines, we saw it in Bangladesh last year, in the Philippines over the last 2 or 3 years, in some regions, the mass incarcerations, severe sanctions for personal possession and use, and so many I got lucky to carry out so many missions for the INCB in many countries. When you think that in certain countries, the judges have no option but to put in jail for 3 years at least any adolescent, any minor with less than 2 grams of cannabis in the pocket. I mean, this is something that the conventions need to look into in a very strong way. Alternative to incarceration is crucial. Access to science-based treatment, access to information prevention. It is not written clearly in the conventions. Of course, we're not used to talk about science-based treatment at the time, but more on politics. Also, the issue of cannabis. Where are we going with the issue of cannabis? The word of cannabis. I mean, we're using the word of cannabis for cannabinoids, for cannabidiol, for medicinal cannabis, for hemp, for every single thing that has to do with the plant and with the derivatives. Cannabis, I think the international community needs to sit down and look into the wording and the formulation, because this is a very important, especially for the perception that youth have of cannabis. When you legalize cannabis, even for medical use or for industrial use, young people think that it's for recreational use. Make difference between cannabis and cannabinoids, and I think we need to go to work on the wording. Also, medical, medicine, and recreational. Which law for which purpose, for which population? The impact on youth, the politics versus the public health versus the economy versus the philosophy. What do we want for our societies? What kind of societies do we want? I mean, this is a very important, and I think there is a link. I think the philosophy speaks to policy, to policies and to politics, and politics should speak to economy and vice versa. The economy of the cannabis legalization, let's be honest about it. Let's be really straightforward. This is about money, nothing else. Also, the science versus the business of the medical cannabis. I'm sure medical cannabis has very important implications. I mean, and applications and important indications, and it is of course useful. But let's look at the science of it in a very clear manner. The monitoring and evaluation of situation. We're still waiting for the monitoring and evaluation in Uruguay. We're still waiting in many states in the US. We're still waiting for an evaluation in many countries, and it's not there yet. So to sum up the challenges, rapid emergence of new psychoactive substances with enormous public health threat. Poisoning with NPS is skyrocketing. Intoxication with NPS is skyrocketing. And we don't even know how to treat them. We don't even know how to detect and early, of course, screen for them. And the global market for synthetic stimulants is expanding. Prevention is not substance specific. Prevention of illicit use of synthetic stimulants is still problematic because we don't know how to prevent those kind of substances. So there's a lack of specific treatment programs for those synthetic drugs and other stimulants. Also, the challenges are the health centers versus punishment approaches. In many conservative countries, where I mean, just keep in mind that in some countries you're being hanged. I mean, in the street for possession of drugs. I mean, for personal use. So this is something that really that needs to be approached on international perspective. Growing misuse of prescription drugs, painkillers. With opioids, benzos. The problem is what's happening in North America is really actually is putting a huge pressure on countries where there is so little access to painkillers. For example, in African countries, where some decision makers are actually shifting from willing to promote access to painkiller drugs to really to refraining from that and to be very cautious about that, wrongly, by the way, because people need to have access to those painkillers. They need to have access to drugs to alleviate, of course, their symptoms. Of course, the way of cannabis, and I talked about this, and the new technologies that threaten the efficacy of law enforcement efforts. Every time I go to carry out missions for the INCB, I encounter the same complaints, either from the customs services or from the law enforcement officials. We don't have enough resources, either material resources or human resources, to tackle the new technologies, to tackle the dark net, to see how things are evolving in our communities and in our countries. Data collection analysis is not routinely rooted in many countries, especially in Africa and the Middle East. So finally, the whole current legislation approach to focus on the consequences of drug use, and they do not mention factors and determinants for drug use. And I think, and I think you all know that this is not a cup of tea for politicians to focus on determinants or on factors and risk factors, whether it's urbanization, whether it's low income, poverty, no access to treatment, and no access to proper, lifestyle, to proper income, social, environment, and economic factors that could lead to not only initiate drug use, but also maintain the drug use and aggravate the drug use, and of course, triggering addiction. I'm gonna skip this. I'm gonna skip it. So the way forward, the legislation do need a thorough lifting. Member states need to identify best ways to how balance the drug control system. They need to put more focus on health and respect for human rights. The emphasis should be put on the person, as I already said. Educating and fighting stigma is really crucial. It is time also to reflect a new legislative framework for the drug problem in the world, whether our conventions, treaties, or some sort of other mechanisms or frameworks for legislation or laws. Drugs behaviors, perception are changing. The law must change also. They cannot be reached without a common and shared responsibility, because it is an international issue, and it has to continue to be a shared responsibility, international issue. So the next convention preamble should start by concerned with the health and welfare of mankind, considering that people for many reasons may experience drug use throughout their lives at a certain point of time, considering that drug abuse is a chronic relapsing medical condition. And if you do that, the implications are, it is likely that you become a drug user if you're a human being one of these days. That could affect anyone in any part of the world and in any cultural setting. That reduces stigma. That also pushes for prevention and early detection. And also we focus on determinants to understand why. And of course, it can also maybe soften the legal consequences, especially in youth. If you consider that drug abuse is a chronic relapsing medical condition and it needs to be written clearly in the conventions, the implications are huge, because they infer access to proper and science-based treatment programs, even of course in prisons and elsewhere, access to rehab and access to harm reduction programs, and most of all, access to dignity. Thank you very much.
Yeah. Nico, you have some comments?
Yes. I think that this has been a really good and very interesting session. And I hope also for tomorrow. And if we have a little time to discuss, I have a question for Ifra. Ifra?
Yeah, we have about 5 minutes of discussion.
Yeah, but I have a question for Ifra regarding the depression in substance use disorder. There is the same syndrome, there is the same way to make a diagnosis, or the depression in substance users is different, is a different syndrome, and we need to know another kind of symptomatology to make a real diagnosis of depression in in this kind of a patient. And this is a question.
I have another question for Mark Potenza.
Thank you.
Okay, my question, Mark, for you. I'm wondering why you didn't try with stimulants in order to treat gambling disorder, because stimulants improve impulsivity. That is not the exception, is the expectation in all people, in majority of people, more severe people who are suffering from gambling disorder.
Yeah, so that I think is a very appropriate question about the potential benefit of stimulants in gambling disorder, given their role in improving impulse control, as well as other aspects, including attention and focus, as well as individuals who have comorbid or dual gambling and attention deficit hyperactivity disorders. So these are all important points. There are also, as with the use of stimulants in individuals, the potential for abuse liability, so that needs to be balanced. And perhaps with some newer formulations, there may be less concern, but I think it's one that one should be aware of. And I think one does need to, on an individual basis, consider the use of stimulant medications.
Okay, thank you for your answer. I think it's a very interesting field of debate because we can compare with opioid abusers, and we are using methadone or buprenorphine, and without any problem, without any barrier. And when we are changing stimulants or gambling, we are thinking in different way. Okay, but it's another debate.
Well, I would also add that with opioids in the treatment of pain, that was thought to in part lead to the opioid epidemic, at least in the United States. So I do think we need to be mindful of both, because you're absolutely correct in terms of methadone, buprenorphine being very helpful for people with opioid use disorders, that we do need to look at both the potential benefits and possibilities for harm.
Thank you.
Yeah, I think that's a question for Professor Kaminer. No? Well, I don't know if Yafra is always there and waiting. Perhaps I have a question or a comment for Professor Jalal Tawfiq, asking him if there are some new convention in the pipelines in the UN.
They're not, because I think the last UNGAS, of course, stressed out is the a very relative consensus on the still, let's say, to put it this way, relevance of the existing conventions. What's in the pipeline, I think, is the discussion around cannabis. Of course, you're all aware of the recommendations of WHO in terms of rescheduling cannabis, and in terms of not only rescheduling cannabis, but also having some adjustments in the with regards to the tinctures and regard to the derivatives of cannabis. The vote will be in December with regards to the ECDD, WHO ECDD recommendations. We'll wait and see how things will evolve, but that's about it. I don't think this is about the whole conventions, as it is about parts of the, let's say, of some paragraphs and some articles in the conventions.
Thank you. Perhaps Ifra is there?
I think he may be off again.
He's off again? Well, I don't know if Ken is always there. Ken? No? Well.
No.
Ken is there.
I am here. Hello, Mehdi.
Hello. Yeah, because, well, just, I find it very interesting development of the brain and the relationship between brain and mental disorders. And do you think that it will be able in the next future to have biological markers and indicators to know what is happening during the evolution of the child and later the teen and the adult?
I can assume we're going to advance to that point someday, Mehdi. Whether it's biological markers as well as epigenetic markers that also might inform, trajectories. This surely is, the epigenetics is surely getting looked at. Can, to what extent does early, for example, stress lead to changes that might impact neural structure, neurodevelopment, as well as stress response, etc. Your question has reminded me of a common one I get, which is, how much is social media impacting adolescent brain development? Because of the rapid, acute, I'll call it indulgences by teenagers in just the last maybe 2 decades or decade of use of social media. And does that have an impact on actual neurobiological changes that then have downstream changes? There's surely a lot of psychosocial things that could be talked about with social media, the good and the bad and the ugly. But spending a lot of screen time, people are asking, well, how much does that affect brain development? That one is probably I know it's getting studied. If people will be able to figure out cause and effect, there's going to be another challenge.
Thank you very much, Ken. Thank you very much. Ikro?
Can you hear me, Madi? I'm kind of getting in and out of contact here. Can you hear me? This is Yifrach.
Yes.
Oh,
yeah,
okay.
yeah. We can hear, but not see you, but we can hear you.
Okay. I don't know if you want to see me, but okay. Yeah, I had some issues. Okay, now
we can see you now.
I know. I know. Ikro had a question. Ikro, would you kindly repeat your question?
Yes, of course. I am interested in knowing if the depression, the depressive syndrome is the same in substance use disorder and in standard depression. In your experience, there is same symptom of the depression, or there is some different symptoms, and we can make a different diagnosis of depression in substance users or not?
Yeah, well, it's an interesting question. I've been collaborating with the people from Duke University that were involved in the largest study of depression per se, no substance abuse in North America. One is called TADS, Treatment of Adolescent Depression. The other one called TORDIA, which is a treatment of depression that is resistant to treatment. And then there was the third study called TASA, which is treatment of adolescent suicide. These are the 3 largest studies conducted in the United States that have to do with depression. They were multi-site, I think like 13 sites, so they will have enough patients. Now, I'm mentioning it because the site at Duke that I've been working with, because I'm like the expert on substance abuse, and the people at Duke were part of the 3 studies, is that, first of all, when they conducted the study on the treatment of depression, substance use of any kind, this was the early 2000s, was an exclusion criteria, meaning they did not accept kids who were substance users, and also they did not accept kids who were suicidal. However, given the trajectory, the developmental trajectory of these disorders, during this 5-year study, as you might imagine, some kids developed substance use disorders, and some kids also were suicidal. So this is kind of very interesting when you do research with adolescents, because they're still, forming and things are developing. So what they found is that those who develop substance use disorder had more difficulties in recovering or getting remission from depression, which was primary, it was clearly primary. And secondly, that they were more difficult to treat. And at that time, I'm talking now 2007, 2008, dual diagnosis wasn't a very common term, even it took, while to develop another 10 years or so. So now let me kind of jump to where we are. Actually, before that, because Mark Potenza is here, so it reminds me, there was a very large study that was, the center of it was at Yale, and they were studying, it was also a multi-center study, looking at adults from age 18 to 30 years to see what was primary, substance use disorder or mental health issues. And they found that in young people, 3 out of 4, the mental health issue come first. So this is not a surprise, because we know that the median age of most psychiatric disorders is earlier than substance use, even though substance use now, unfortunately, is the age of first-time use is decreasing. So getting back to our issue again, and I'm sorry about this kind of elaborate response, I am not sure anymore that the symptoms are more important than the severity, meaning that what happens, as I mentioned, if you have sub-threshold, you don't have 5 symptoms, you have only 4, 3, or 2. What we have found in this study, and again, we're still looking at data and stuff, that the number of symptoms was not as important as the severity of the symptoms on the score on the child disorder rating scales. And a lot of time I say to students, you always focus on the diagnosis, which is very dichotomous, binary, because we MDs, we like yes or no. But there's a lot of things in the middle. And I said, actually, the severity is probably more important because the severity affects the function. It causes dysfunction. Therefore, we have concluded in this study that the severity score is much more important, meaning that recovery is not a matter of number of symptoms, but a matter of score. And I'm sure that there's all kind of sophisticated statistics that show that the relative weight of each symptom of depression is not necessarily similar to other symptoms of depression. Therefore, it's more of a matter of severity. This has been my experience during this study. So excuse my long answer to you, but this is where I'm heading with this issue, that severity and dysfunctionality are probably more important than the specific symptom per se.
Probably, but we must consider that probably the resistance to treatment probably is due to a variant of the depression in substance users. There is not the same depression. If there is comorbidity, probably it's the same depression, but not in all patients with the substance abuse.
I think that the point, Ikro, that we should focus on in the future, again, because we need to be pragmatic, what's in it for the patients? How are we going to treat them? And in my experience as a child and adolescent psychiatrist, many of these kids have already shown symptoms of depression before substance use. Furthermore, some of them who show first episode of depression actually are bipolar. And the first episode is depression and not the manic or the hypomanic episode. So you don't know if they will switch into the manic episode. And you know, sometimes when people give them antidepressant, it accelerates the switch to bipolar. So this is only where we can see family history as helping information. So that's truly fascinating. That's why I'm really interested in, you know, you can handle all the mental disorders, but that's why my focus is on depression. That's why I'm collaborating with the other group and also with suicidal behavior.
Thank you. I think we have a minute perhaps for Ken, and then we close. Yeah, Ken?
Actually, Yifra, here's one other way of asking that question. If you had a group of teenagers with just depression, no co-occurring substance use, and their onset of the problem was the same age as a group of teenagers with depression and co-occurring substance use, which group would have the more, forget about number of symptoms, I'll go to your point, which group do you think would have the more severe depressive symptoms?
Well, I'm gonna, as a psychiatrist, I'm gonna answer your question with a question, and actually you may know the answer. There's somebody actually from your group, I forgot his name. He's done, of course, I found the publication afterwards and sent it to you. He asked the question even more emphatically. He said, not only what came first, the chicken or the egg, what maintains the continuity of symptoms, both of substance abuse and depression. And one of the findings is that if you have co-occurring conduct disorder, which is very common, the higher likelihood that this depression and substance disorder would continue as compared to not having it. And I just realized from the data that we looked at this week, honestly, it's so fresh. I mean, I'm sharing with you stuff that is boiling. It's hot from the oven, that we found that early onset responders usually are more likely not to have conduct disorder. Those who have conduct are not early onset responders. So as you know, Nestor probably would like it. It's not dual diagnosis, it's triple diagnosis, quadruple diagnosis. You have several diagnoses, and any additional diagnosis worsens the outcome.
We were supposed to stop at 10 o'clock. We have some minutes more. Well, I would like to thank warmly all the speakers. It was a pleasure to listen to you. And I have some comments from participants who are very, very, very happy. And they say a lot of very good words about what they have listened, what they have learned. And I would like to thank again Nestor, Ken, Yifrah, Jalal, Mark, and Ikro. And I give you, for those who are listening to us, a rendezvous tomorrow at 7 o'clock UTC time +2 and 6 o'clock Moroccan time. Perhaps I give the floor to Ikro if you want to add something.
No, I'll see you soon, tomorrow.
So, thank you very much, and bye-bye.
Bye-bye.
Thank you very much.
Good night from Spain, from Madrid.